Welcome, everyone, and thank you for taking the time to learn about brain injury and those we serve. This webinar is intended for professional audiences, such as our referral partners and local organizations who may and likely have encountered people living with brain injury. My name is Jess, and I'm an intake case manager with Brain Injury Services. We're a nonprofit organization, and we provide free community-based services throughout the Northern Virginia region. And today we're going to cover the basics of brain injury, including what it is, how it affects people, and how we can better support individuals and communities who have been impacted by it. And so by the end of this webinar, you'll have a better understanding of basic anatomy and functions of the brain, key brain injury terminology, common symptoms and treatment approaches, and we'll also address some common misconceptions as well as some practical strategies that you can use in your work. Before we begin, it's important to note that brain injuries can be similar in many ways, but there's no one size fits all. And so what we discuss today may or may not apply to each person's situation. Additionally, this training is for educational purposes only and is not medical advice. And so to get started, we'll discuss the basics of brain injury. And so what is a brain injury? You might hear the term acquired brain injury or ABI, which is really like an umbrella term for multiple types of brain injuries. And so an ABI occurs when the brain is damaged due to trauma, medical conditions, or other factors. And these events occur more than 30 days after birth, and they are not part of a genetic, congenital, or degenerative condition. So, for example, a person with epilepsy does not automatically have a brain injury, although they may acquire a brain injury if their seizures maybe result in a fall or damage to the brain over time. And so an acquired brain injury or an ABI includes traumatic and non-traumatic injuries. When we talk about traumatic versus non-traumatic, we're speaking really in terms of physical trauma, not psychological. And so a non-traumatic brain injury is one that occurs from an internal force, such as a stroke, a ruptured aneurysm, anoxia or hypoxia, meaning oxygen to the brain has been impacted, infectious disease such as meningitis or long COVID, as well as tumors, cysts, or toxin exposure. Whereas a traumatic brain injury or a TBI occurs from an external force and it can result in an open or a closed head injury. So, as you might expect, an open head injury might include something like a penetrating injury, maybe a brain surgery or a skull fracture, whereas a closed head injury would be maybe a concussion, a contusion, which means bruising. A diffuse axonal injury occurs from shaking or strong rotation of the head, such as, unfortunately, in shaken baby syndrome, or by rotational forces, such as in a car accident. The term coup contre coup occurs when there's damage in two sides of the brain, meaning the site of impact and the opposite side of the brain due to force causing the brain to move within the skull. So, traumatic brain injury or TBI has several common causes, such as motor vehicle accidents. That's a really common one. But the most common cause is falls, which makes up about 40% of all TBIs. And TBI is a lot more common than people think. A 2025 meta-analysis showed that across the US general population, there's an 18.2% prevalence of TBI. Now, this doesn't necessarily mean that every concussion or TBI will lead to long-term effects, but it is important to know how common they can be. In general, the literature shows that men are more likely to experience a TBI, and this is usually because men on average are involved in things like contact sports, physical labor jobs, military service, and sometimes risk-taking behaviors or substance use, all of which can increase their risk for injury. However, we also recognize that a significant portion of TBIs in women are underreported or untreated globally due to things like domestic violence. The highest risk age group is 15 to 24 years old, but children under 5 and adults over 75 are also at a greater risk, mostly due to falls. The big point here is that TBI does not discriminate and can affect anybody at any age. And in the past, TBIs were classified as either mild, moderate, or severe, based primarily on clinical symptoms only, such as loss of consciousness or post-traumatic amnesia. However, this system didn't really accurately reflect many people's symptoms or recovery paths. For example, a concussion used to be called a mild TBI, but A concussion, as we know now, can lead to really profound and lasting impacts. And so the field has shifted to this new approach called the CBIM, which looks at multiple pieces of information to better understand the whole picture. And so we're still taking into consideration clinical symptoms like that loss of consciousness, maybe dizziness, headache, light or noise sensitivity. But we're also now looking at other pieces of information like biomarkers or blood tests, imaging, so a CT or MRI scan, as well as modifiers, meaning individual factors that can influence somebody's outcomes, like their age at the time of injury, their sex assigned at birth, their medical history. Maybe they have other co occurring medical conditions that are kind of impacting how their symptoms present, as well as their environment, like their support system. And so by moving away from the mild, moderate, and severe labels, and by using this new framework, the CBIM, we can better understand each person's injury without minimizing or pathologizing their experience. Moving on to non-traumatic brain injuries, or NTBIs, these injuries, again, do not occur from an outside force, like a fall, a car accident, or a blow to the head. Instead, these injuries are because of internal factors, meaning things happening inside the body that affect how the brain works. The most common example is a stroke, also known as a cerebrovascular accident or a CVA. A stroke happens when blood flow to part of the brain is blocked or when a blood vessel bursts and the brain cells in that area don't get the oxygen that they need. Other internal causes, again, can include a lack of oxygen to the brain, such as, for example, during cardiac arrest, as well as infections that reach the brain, tumors, cysts, or toxin exposure. And again, the key idea here is that the brain is injured not by an external hit, but by something going wrong within the body itself. And there are a few different types of strokes. By understanding the basics, this can help us make sense of why people may have different symptoms or recovery paths. And so an ischemic stroke is the most common type. And this occurs when a blood clot blocks a blood vessel in the brain. Think of it kind of like a pipe getting clogged. And so the blood can't get through, and that part of the brain isn't getting the oxygen that it needs. A hemorrhagic stroke occurs when a blood vessel bursts or leaks. And so instead of a blockage, there's actually bleeding inside or around the brain. And this bleeding puts pressure on the brain and can damage nearby cells. And lastly, a transient ischemic attack, also known as a TIA or a mini stroke, is caused by a temporary blockage of a blood vessel. And these symptoms might look like a stroke, but maybe go away within minutes or hours. And even though these symptoms go away, a TIA is a warning sign that a real stroke could happen without treatment. And so all of these different types of strokes can involve blood flow problems, just in different ways. And like TBIs, strokes are very common and a major cause of long-term disability. In the US, a stroke occurs about every 40 seconds, and that adds up to almost 800,000 a year. Of those, 600,000 are first-time strokes, which means that about 1 in 4 people who have had a stroke may have a second one. Next, we'll walk through some key parts of the brain and what they do. Starting off with the frontal lobe, seated just behind the forehead, this area of the brain acts like a CEO because it manages executive functions, which are higher level cognitive skills, such as planning and organizing, task sequencing or following the order of steps in a task, abstract reasoning, impulse control, and decision making. And so damage here can disrupt our ability to use these skills, these executive functions, as well as to regulate our emotions, to start or finish tasks, to stay focused and motivated, and to be able to tolerate frustration. And so you might notice that these symptoms seem a little bit similar to ADHD or attention deficit hyperactivity disorder. And that is because executive dysfunction can occur in both ADHD and in frontal lobe injuries. And so next we have the temporal lobe, which is seated kind of behind the ears. And so the word tempo helps me remember this because this part of the brain is responsible for language, memory, and fear emotions. And one common result of damage in this area is aphasia, which really means trouble communicating. And with receptive aphasia, the person might have a lot of trouble understanding information they receive, receptive. And so their responses might not make sense as a result. Alternatively, expressive aphasia is when a person has trouble maybe finding the right words to really articulate what they mean, or they might have trouble physically producing the words they're trying to say. And so, in addition to these communication challenges or aphasias, damage to the temporal lobe can also lead to changes in aggression and even PTSD or post traumatic stress disorder due to its link to fear emotions. The parietal lobe sits across the top of the brain, kind of like a headband. And so, this area of the brain manages our five senses. It interprets, perceives, and integrates sensory information that's communicated by the body. And so damage here can result in an inability to coordinate movement, to understand where our body is in space, and to respond to sensory information in an appropriate way. For example, we often see clients experiencing a lot of overstimulation due to these sensory changes after a brain injury. The occipital lobe is home to our visual processing area. This part of the brain, kind of near the back of the head, is responsible for making sense of visual information that it received from our eyes via the optic nerve. This allows us to understand things like distance and depth perception, to recognize colors, objects, and faces, and to form visual memories. This means that damage in this area can impact these functions, and it can also result in things like full or partial blindness, double vision, or other visual conditions. The limbic system is another important area of the brain. This is highly involved in our emotional and behavioral responses, especially our survival instincts, like the fight, flight, freeze response. And so damage to this area can lead to us getting stuck in that state of dysregulation or fight, flight, freeze, and it can also lead to hormonal disruptions. The cerebellum and brainstem are two of the more primitive or early brain areas. The cerebellum is responsible for our motor functions, such as being able to coordinate movements and to maintain our posture and balance. The brainstem is responsible for involuntary responses, such as our heartbeat, blood pressure, breathing, sleeping, digesting. These are things that we generally do without having to think about them because our brain kind of handles them automatically. And so the lobes of the brain that we just discussed exist across two hemispheres or halves of the brain, which are divided by a groove known as the longitudinal fissure. And while this is a simplified model, the left brain is often associated with logic and language, and the right brain with creativity and intuition. These two halves of the brain control opposite sides of the body. This means that the right brain controls the left side of the body, and vice versa. And so, this is why a person who experiences a stroke on the right side of their brain may have left sided weakness or loss of mobility. But the left and right hemispheres are united by the corpus callosum, which is really a large bundle of nerve fibers. And so these two parts of the brain work together as a team. And there's even evidence that parts of the brain can take over or compensate for a damaged region. And so now let's look at how brain injuries show up in everyday life. Brain injury can affect many different parts of life, and the effects can be short term, meaning as little as 2 days to a few weeks, or they can be long term and even lifelong. These effects can range from mild to severe, and they may impact cognition, sensory function, physical abilities, and emotional and behavioral health. As a quick reminder, brain injuries aren't identical, and so while there are common themes, not everybody has the exact same combination of symptoms. And so when we talk about the impacts of brain injury, it's important to note that you may not even be able to see some of these changes caused by brain injury, which is why it's often referred to as an invisible disability. So some common physical symptoms after brain injury can include motor function loss or weakness, meaning trouble moving certain parts of the body, difficulties with communication, also called aphasia, so problems with speaking, understanding, reading, writing. Physical symptoms can also include seizures, headaches, chronic pain, fatigue, trouble with balance and dizziness, as well as sleep problems, whether that's trouble falling or staying asleep or experiencing quality sleep. And these effects can vary widely depending on the area and the severity of the injury. Brain injuries can affect many of the senses as well, even if the eyes, ears, and sensory organs themselves are physically healthy. And this happens because the areas of the brain responsible for processing sensory information may be affected, even when the physical pathways are still intact. For example, even if somebody has 20/20 vision, their brain might not interpret what the eyes are seeing correctly, leading to trouble judging distances or tracking moving objects. This is why it's important to identify which areas of the brain are affected and to work with specialists who can help us determine the root causes of brain injury related symptoms. So, some visual changes again might include blurry or double vision, trouble with depth perception or visual processing. Hearing changes might include sensitivity to sounds or noise, difficulty hearing clearly, or ringing, buzzing, or humming in the ears. Other sensory changes can include altered touch or taste sensation, changes in smell, as well as some sensory overload, meaning that sights, sounds, or touch can feel way more overwhelming than they used to. And these sensory changes can make everyday activities like reading, watching TV, cooking, or being in busy environments that much more challenging and fatiguing. So, brain injuries can also affect the basic thinking skills that we use every day. Some common changes in these basic symptoms include trouble concentrating or staying focused, a short attention span, feeling confused or kind of foggy, like the brain fog post COVID, slower thinking or processing of information, difficulty understanding what others are saying, memory problems like forgetting recent events, instructions, appointments, and learning new information more slowly. And so these changes make everyday tasks like work, school, and social situations even more challenging. And changes in these cognitive skills contributes to the invisibility of brain injury because these challenges can be present or even severe despite somebody looking fine from the outside. And you may remember from an earlier slide that the frontal lobe, or the CEO of the brain, is home to our executive functioning skills. And with executive dysfunction, again, some common challenges include trouble planning and organizing, maybe starting or finishing tasks, staying focused, problem solving or making decisions, and sometimes also reduced insight or self monitoring, meaning it can be hard to notice mistakes or know when to adjust. And these changes can show up again in everyday life in ways that feel frustrating or confusing. Again, missing appointments, forgetting the steps when we're cooking, or struggling to decide what to do first. And sometimes a person knows exactly what they want to do or what they need to do, but they still fall short because of their brain injury symptoms. And so cognitive rehabilitation and adaptive strategies aim to help individuals work around these challenges, maybe using checklists, alarms, planners, step-by-step instructions, or structured routines to help us manage daily tasks and regain a sense of control and independence. Brain injuries also commonly affect mood and behavior. And so some common examples include irritability, meaning feeling annoyed or upset more easily, frustration, especially with certain tasks or challenges, aggression or agitation. So in children and teenagers, this might look like acting out or more tantrums. And they can also lead to depression, anxiety, or even apathy. And so it's important to know that many of these changes can be exacerbated or caused by the brain injury. And as such, they're typically not personal or intentional. And so support, therapy, and coping strategies can help us to better manage these symptoms. Brain injuries can also affect how somebody controls their behaviors, emotions, and social interactions. And so common examples include disinhibition, meaning saying or doing things without thinking, impulsivity, so acting quickly without considering the consequences, personality changes, impaired self awareness, changes in our social skills, trouble regulating our emotions, especially when we feel overwhelmed, angry, or sad more easily. We also might feel our emotions more intensely. So, stronger reactions, larger reactions. And these changes can be frustrating for both the person with the brain injury and their loved ones, but they're a common part of recovery and can improve with support and strategies. So, next, we'll shift to how recovery and supports really work. And so, at any stage of recovery, a person with a brain injury might interact with members of the treatment team shown on this slide. And if we compare the treatment team to a football team, the coach is often a neurologist. And this is a medical doctor who specializes in conditions of the brain and spinal cord, and who helps to manage care, monitor progress, and coordinate treatment. We might run things by them like medication changes, lifestyle changes, or updates on any new conditions such as diabetes or a chronic condition, so that they can adjust the game plan accordingly. Other team members might include occupational therapists, physical therapists, speech language pathologists, or even neuropsychologists and social workers. And these members may or may not be involved depending on each person's individual needs, and they may not all be involved at the same time. And so the important takeaway here is that the treatment team works together to support and to advocate for the person in their recovery. And so, how does recovery actually work? An important term to know is neuroplasticity, which is the brain's natural ability to change, rewire, and reorganize its neural pathways throughout the lifespan. Brain cells, also called neurons, join to form electrical pathways that power activity within the brain. And so, in addition to other repair processes, neuroplasticity supports damaged brain areas to reconnect injured routes or to find detours, so to speak, to restore brain function. This means that in recovery, the brain can literally find a way or make one to regain critical abilities. And we promote this by exposing ourselves to new experiences, such as learning opportunities. Now that we've talked about neuroplasticity, let's introduce another important idea, which is cognitive reserve, which you can think of as the brain's backup system. And so research shows that people who stay active mentally, socially, and physically tend to keep their brains healthier over time. We can think of this as contributing to your brain's bank. And so your brain's bank is made up of all of the knowledge, skills, life experiences, and healthy brain cells that you've built throughout your life. When the brain is injured or stressed, it relies on this reserve to help keep you functioning. And so it's one of the reasons that two people with a similar injury might have different outcomes. The good news is that cognitive reserve is not fixed. And so you can continue building it by staying engaged, meaning doing activities you enjoy, learning new things, connecting with others, and moving your body in ways that are safe for you. So when we talk about recovery strategies, part of what we're doing is strengthening this backup system, meaning giving the brain more tools and pathways to work with as it heals. So a common question we hear is, how long does recovery take? And unfortunately, there is no clear answer. Since no two injuries are exactly the same, that means no two recovery paths are exactly the same. Fortunately, we know that progress is not only possible, but it can also be ongoing. And so a 2018 study on TBI found that even at the 10-year mark, some patients were still improving. And so at the 2-year mark and at the 5-year mark, patients who still needed assistance with activities of daily living or ADLs had actually regained their functional independence by 10 years. And this means that progress may continue for longer than we originally thought. In the past, we've heard experts say you might plateau or reach maximum medical improvement at 6 months, at 1 year post injury, or around 2 years. But now we know this can keep going on with intentional efforts. And so now let's talk about some practical strategies that you can use in your professional work if and likely when you encounter folks living with brain injury. And so in an earlier slide, I referred to brain injury as the invisible disability, meaning that for many people, it's difficult to tell what they're experiencing internally. And so similar to an iceberg, we might see what's on the surface. Maybe the person is walking and talking independently. Maybe they're driving, volunteering, working, and they seem generally healthy or, quote, normal. However, with a brain injury, there might be all of these things under the surface that we are not seeing. And that can include mental health symptoms, so that depression, anxiety, maybe PTSD from how the injury occurred. We might also not be seeing dizziness or balance issues, fatigue, sleep difficulty, pain, sensory changes, cognitive changes, personality changes, as well as the social isolation that often occurs after a brain injury. And so it's not uncommon for these brain injury symptoms to be mistaken as personality or character traits, or even mental health or substance use symptoms. But what if these signs and symptoms were actually the brain trying to tell us something? And so we want you to consider low motivation, what we might assume about another person, might actually be cognitive fatigue, meaning their brain is exhausted after what might not have been an issue for them before. We might assume that avoidance or somebody is avoiding a task is actually a challenge with initiation. They're having a really hard time getting started. And it's not that they are avoiding it or don't want to do the task, they're having a hard time following through. What we might assume to be lack of focus might be that the person is having a hard time processing information. We might assume somebody is careless, but they might actually be forgetting the steps that you told them or the instructions you gave. We might assume somebody has emotional reactivity or a mental health concern. This might actually be a reduced regulation capacity, meaning they're having a harder time regulating their emotions. We might assume someone is irresponsible, and this might actually be reduced impulse control. And again, a mental health condition might also be an underlying neurological condition. And so, as a professional who can and does encounter brain injury survivors in their everyday work, here are several TBI informed approaches that you can adopt into your own practice. And so, first, we can help clients through grounding and co regulation techniques to regulate that nervous system that may be stuck in fight, flight, or freeze. We can also slow the pace by maybe pausing, asking for feedback from the client, such as, is this going too quickly? We can also reduce the cognitive load, meaning that if we have a lot to cover in one meeting, maybe we spread it out across two or multiple meetings in smaller contained doses so it's less of a burden on that person cognitively. We might also reduce light, noise, and distracting stimuli to accommodate sensitivity to sensory stimulation. And we can also consider the time of day, day of week, and length of meetings, meaning scheduling around a day or a time that the client typically feels best. Oftentimes, I hear clients say that they are feeling best in the morning, and by mid-afternoon, they're not feeling so great. We can also track cognitive fatigue, meaning that if we notice changes in the client's energy, their speech, focus, or their mood, it might be time to check in or put a pause on things. And so we also want to avoid assuming that verbal fluency mean the person has the capacity to handle as many cognitive demands as we assume. That said, we want to normalize the experience rather than judging or shaming this person. And lastly, we want to see the whole person. We want to take a holistic lens. And so, for example, a person with a TBI has experienced some physical trauma, and maybe this has also resulted in psychological trauma or social isolation. And so, we want to see the whole picture. So, the key idea here is that awareness and empathy can promote greater understanding and better outcomes for those we serve. And so these are some evidence-based tools that you can use to identify a possible brain injury and to connect individuals with the right supports. And so these tools come from a variety of resources. The first comes from the National Association of State Head Injury Administrators, or NASHIA, and they have an online brain injury screening and support system. Here in Virginia, through the Department of Aging and Rehabilitative Services, or DARS, there is also a Virginia No Wrong Door program, which offers a brain injury screening tool. Additionally, for possible domestic violence survivors, the Ohio Domestic Violence Network offers a couple of screening tools, such as the CHAT screening tool, as well as a HELP screening tool. And lastly, here, The Ohio State University has published a TBI identification method, as well as a training resource for professionals who want to learn how to use it. So in addition to these screening tools, there also are a variety of resources available with more information about brain injury and what else is available. And so under the umbrella of the Brain Injury Association of America, there's also a brain injury association throughout each state in the US. And so our agency, Brain Injury Services, is one member of an alliance of sister organizations throughout the state of Virginia under the Brain Injury Association of Virginia. And lastly, here, the Unmasking Brain Injury Project is an additional resource to learn more about that invisibility of brain injury and what's under the surface or under the mask directly from the voices of survivors themselves. And so if you have questions about brain injury or our programs, please feel free to reach out to us through phone, fax, or our website referral form. And so thank you so much for attending this webinar and for your dedication to supporting our shared community.